Have Dr. Rehan available. I can't believe he's actually awake. It's 2 a.m. in Nairobi.
I'm very much awake, Sachin. Nice to see you guys.
Yeah, thank you, Rehan, for being here and being a part of Rmie. We really appreciate it. So let's get started with a few questions for our expert panelists. Um, there's a question from the audience, and I'll let Wani, you and Rehan address this. Do you have a stopping point for Barrett surveillance when they've had multiple surveillance upper endoscopies with no dysplasia? So these are your patients with non-dysplastic Barrett's.
So with non-dysplastic Barrett's and surveillance, we can look to, what their life expectancy is and what their overall health is, and that is an individual decision making. Sometimes we stop surveillance, around the age of 82, 83 for colon cancer and for Barrett's, but for 75, it might be at age 75, we might think about it for individual patients regarding their comorbidities. Regardless, I think it's an individual decision making, and it depends on their life expectancy. Rehan, do you want to add anything?
I think we've got a lot of very robust long-term data now on the durability of endoluminal therapies for these diseases, and we know the recurrence rate is really very, very low. And I think you're absolutely right in that we need to take into account the individual patient. And so I think we'll come to a stage very soon that we'll put these patients back into their normal surveillance protocols that we used to do pre-disease. So I completely agree with you that it needs to be individualized.
Perfect. If I can just add, there are observational data suggesting that the more number of endoscopies that you've had that have demonstrated non-dysplastic Barrett's, the lower is your risk for progression to high-grade dysplasia or cancer. And just to add to the comments from Wani and Rehan, we unfortunately don't have really good data to guide us. None of our guidelines actually address this important question that's been brought up, but there are some modeling studies that actually take into account the age of the patient and the number of comorbidities that the patient may have. All right.
Sachin, I think you're absolutely right, because the volume of endoscopies that we do in our endoscopy suites is not insignificant, but we also must put into the fact that I think our endoluminal therapies have improved so much that all of these healthcare models that you talk about need to be taken into account. So I think the risk is really very low now in terms of recurrence. And there is also an important discrepancy between what is recurrence and what is residual disease. And we know that the risk of neoplasia in the first 12 months after what we term as successful endoluminal therapy is highest in the 12 months, and that's when we need to be most vigilant. And I think once we have surveyed those patients and they don't manifest dysplasia in the first 12 months, then we can really relax our intervals, because we know that residual or recurrent disease, or whatever you want to call it, is really very low.
Yeah, I completely agree, Rehan. I think just so that the audience understands, I think we're discussing two important questions here. How long should you continue surveillance in a patient who has never progressed to high-grade dysplasia or cancer? And that's what we just addressed a few seconds ago in terms of how long surveillance should continue in patients with non-dysplastic. What Rehan is also bringing up which is another important question. Once you've achieved complete eradication of intestinal metaplasia, how long are you going to continue surveillance for these patients? And to the point that Rehan brought up, and what Wani did as well in her presentation, recognize that recurrences do occur, and they're most commonly seen in the first 12 months. In some studies, and I would actually argue that these are not true recurrences. These are actually patients who had residual Barrett's or Barrett's-related dysplasia. Most contemporary observational studies suggest that recurrences, true recurrences, actually occur at about 18 months or so after you've achieved complete eradication of intestinal metaplasia. So since we're talking about recurrence, and that was one of my next questions, what's your approach to surveillance endoscopy? And this is open for the entire group of panelists who perform Barrett's-related therapy. Are you taking random biopsies? Are you not taking random biopsies? Are you biopsying just in the distal 2 centimeters, the entire previous length of the Barrett segment? And let's start with you, Vani.
Sure. So in terms of my surveillance, I always use a CAP, use narrowband imaging, use a careful inspection. I take biopsies always at the Z line and into the cardia, about 1 to 2 centimeters, and then the distal 2 centimeters of the esophagus. And then any visible lesions that I see in any of the tubular esophagus, I'll also take, as well as visible lesions in the cardia. I sometimes will still take another jar, maybe not quite as rigorous, but just another jar above that, depending on the length of the segment, the initial pathology, the multifocality of the disease, and the concern I had for the patient. So I sometimes will maybe not take every centimeter, but still sample the rest of the esophagus, depending on what that journey was like.
Perfect. Rehan, what's your biopsy protocol?
Yeah, so Wani, thanks for that. I think that's really helpful advice. But I think that just to hammer home the fact that if it is meticulous resection followed by ablation, which will lead to very, very good results. And so, in the absence of visible abnormalities, I think that I think we're all comfortable that taking biopsies at the neo-esophagogastric junction and probably a centimeter or so below that will suffice. And then obviously, any targeted lesions in the new squamous epithelium, that's what we do. And I think that probably should be the advice moving forward. But it has to be driven by your endoscopic experience, your imaging modalities that are available to you as well.
Perfect, Mohammed.
Yeah. So anytime I see Barrett esophagus for surveillance, the first question to me is if there's nodular mucosa or no. So if there's a nodular mucosa, that's another category because it has to be resected and removed, and we don't know what's going on. If it's flat, then we'll do meticulous inspection. I feel, and I don't know, maybe I'm not a Barrett expert like you guys, that Seattle protocol is too much, and maybe careful inspection and biopsying at the lower esophagus where Barrett esophagus start, and any abnormal area on NBI, maybe having as good yield as Seattle protocol. But I don't know what you guys think about that.
Sorry, are we talking about post-eradication or
Post eradication?
I think that some of the newer data is suggesting that we can limit it to the distal 2 centimeters, but I know a lot of people who still do the Seattle protocol and have not given it up, and so that's why I aim for the hybrid approach. Sachin, you have to weigh in here.
Yeah, no, I think for patients who've achieved complete eradication, my practice is in the distal 2 centimeters. That's where you're going to see the maximum recurrences. And I target my biopsies at the GEJ distal 2 centimeters and close inspection of the gastric cardia. So ensuring that you retroflex, get your scope into the hiatal hernia, I think is critical.
I've converted to that as well. I think we have another question from the audience for Rehan. What is your opinion about Ghrelin and endoscopic management of obesity?
Gosh, that's a big question. So ghrelin and endoscopy don't go together. You know, we're talking about two different. So ghrelin is, you're absolutely right that if you look at the physiology of satiety and appetite, you know, ghrelin is paramount to driving the way that the human brain deals with the physiology of satiety. With endoscopic techniques, we don't have the advantage of what the surgeons can do, which is to, you know, bypass that stimulus. So I think that is what my finishing slide, you know, sort of alluded to, which was the combination of medical therapy to intervene, as well as volume reduction. So I think that, you know, in isolation, endoscopic therapies will not target ghrelin, but with combination with medical therapies, then, you know, we will hopefully be able to delve into that space.
Thank you. And I believe while Dr. Kanda is pulling up a video, we'll do another question from the online group. So I believe this is for Dr. Othman. Is there a stricture length cutoff for performing stricturotomy?
So yeah, so the stricturoplasty is typically is kept for shorter strictures, but it could be used for longer one, but you have to be very experienced and very careful. So there's a high risk of perforation if you do like incision of 10 centimeter in the esophagus. So I would say this is not a technique that I would advocate for use in general, unless you really have a lot of experience using needle knives or ESD knives. But for short stricture, something like a web or a ring, stricturoplasty is perfect, or anastomotic stricture.
Can I just squeeze in one more question before we go to our case presentation? Larissa, I have a question for you. Can you tell me your approach to management of bleeds from Dieulafoy's lesions? Are you injecting and clipping? Are you putting a Novesco? Are you banding? What's your approach?
Yeah, it depends on the size a little bit, but for larger Dieulafoy lesions, I'm leaning towards Ovesco at this point, due to the concern for rebleeding, and just really good hemostasis with the Ovesco clip or an over the scope clip. But definitely whenever I do intervene on a Dieulafoy lesion, I always do make sure to tattoo it, given the difficulty that it can be with finding it later, if it were to rebleed.
And that's a great teaching point. Thank you, Larissa. All right, Ani?
Sure, I'm going to show a couple of cases. This is a 56-year-old man in surveillance who underwent an endoscopy and had long segment Barrett's, and the surveillance biopsies, all placed in one jar, demonstrated low-grade dysplasia, and the patient was referred for additional management. And this is his Barrett segment, and again, looking for any areas where there's irregular contour of the wall or discoloration of the Barrett's. And you can start to see here around that 3 or 4 o'clock area, this nodular area. Again, this is one of those great cases where if you over insufflate, you can insufflate out the nodule a little bit, and so it might not be as readily apparent. So this is where I think really insufflation and deflation help a lot during your Barrett's examination. So taking that time to inspect and look, and then using narrowband imaging. And again, this is with the near focus feature. You can sort of see that transition of a villus appearing area to more of an irregular, distorted area. This other area also caught my eye that was a little bit discolored and a little bit friable. Although I have to say I didn't catch it on the as easily. And here it is on narrowband imaging with distorted, irregular vascular pattern. I wasn't, I'll be honest, I wasn't sure if my cap scratched it on the way in because I didn't see it on the first time. So it took the lesion at 4 o'clock with endoscopic mucosal resection, and that was intramucosal carcinoma. And I wasn't sure if I scratched it or not, so I decided just to biopsy. And lo and behold, biopsies came back intramucosal cancer suspicious for invasion by biopsy. So I don't think it was only my cap. I'm just curious if anyone has any strong opinion about what they would do next on the panel.
That's beautiful illustration, actually, because many people would miss this lesion, particularly the one on the top up there, and the word discolored, unfriable is what really the right description. And this is a tough patient because you have multiple spots of early cancer in multiple areas. So I wonder, what did you do for this?
Yeah, so we went over those points, but did ESD, because there was this concern for invasion of the, and I was quite surprised as well, but I decided once you knew about it, I wanted to definitively treat that area, and that also showed intramucosal carcinoma with muscularis mucosal invasion. So again, endoscopic resection of all visible lesions, including mucosal irregularities. And this case, I don't think you're committed to it, but I think it's appropriate to consider ESD if there's suspicion for submucosal invasive disease.
And please note that Vani did not mention anything about doing an EUS before this procedure. Did you go?
So the patient then had an EUS subsequently. With the initial diagnosis of low-grade dysplasia, an EUS was not initially performed prior to before the
And did
MR.
you do it before the ESD?
Yes.
Okay, got it.
So I honestly feel that EUS is not needed in this
I agree.
case. Yeah. But what happened is that they get referred to us and they already had EUS anyways.
Yeah.
And I have one patient that I told him, you don't need an EUS. We're going to go ahead for ESD. And he got so upset and went to MD Anderson and said, Dr. Rothman doesn't want to do EUS. I'm just saying.
Yeah, I think just for the trainees, I think it's important to note that EUS does a lousy job in actually differentiating between T1A versus T1B. The best way to actually differentiate the depth of invasion is by doing what Dr. Konda did, which is resecting the lesion.
So this gentleman had he was a 74-year-old. He had an endoscopy performed at the time of a screening colonoscopy. Wasn't told anything after the procedure that anything was suspicious. Had Z-line biopsies and high-grade dysplasia was shown on those biopsies. He was brought back 3 months later by his primary GI, and repeat EGD demonstrated high-grade dysplasia. There was no mention of visible lesions. And then he was called over the phone after the pathology results came back by the nurse practitioner and was recommended to schedule an RFA procedure. The patient at that point sought a second opinion. So just to say this out loud, the patient was not offered any clinic consultation, really didn't have the opportunity to ask any questions about the procedure, had questions and didn't have them answered. So this is sort of an example of not counseling and going over risks and benefits of the procedure. This is his endoscopy. And again, sort of looking all around the squamocolumnar junction, looking for any areas of irregularity or raised lesions or areas that don't quite move the way the rest of the wall moves. And so, and looking at the pit pattern and the coloration. And so hopefully by now you sort of saw this area at 2 o'clock that is a little bit discolored and also a little bit raised and seems to be not quite as compliant as the rest of the esophagus. This is it with narrowband imaging and near focus. And you can see a focal area of distortion and loss of pit pattern sort of in the middle of that area. So that area was actually even better seen a little bit on retroflexion in terms of the contour. So doing a good retroflexed examination, performed focal EMR of this area. And this was actually another intramucosal carcinoma with muscularis mucosal invasion with negative margins. So I show these cases to really hit home that we really, I feel like we always talk about, oh, you can ablate flat Barrett's. I really want to urge you to really look carefully for mucosal irregularities and resect mucosal irregularities because these two cases could have been called flat Barrett's and they both had muscularis mucosal invasion in the setting of intramucosal carcinoma and would not be appropriate for radiofrequency ablation. So.
Perfect. Thank you so much, Vani. If we can pull up the final few slides. While I'm doing that, we truly did save the best for the last. And I want to thank Dr. Konda and Natalie for co-moderating the session with me. Larissa, thank you so much. And of course, Dr. Atman and Rehan, thank you, my friend, for all that you did for RMIE. And I can't wait to see you in person. Thank you. All right. So with that, this brings RMIE to a close. I want to thank you all for attending and again taking the time to be a part of this educational event. I want to start off by thanking all the faculty members. These are some outstanding group of individuals who worked tirelessly over the past 3 days to perform live cases, do hands-on training, and give you some state-of-the-art lectures. We certainly learned a lot from all of them. A huge thanks to our sponsors. These are all individuals and companies that provided educational grants. You can see the companies that were categorized as our platinum sponsors. That was Boston Scientific, Cook and Olympus were our gold sponsors, and Rmie was our silver sponsor for this event, and the bronze sponsors listed on this side. We also want to thank all our exhibitors that contributed and for their generous support. This is how you can get your CME. This event actually provides CME, ABIM, mock points, NCPD, nursing contact hours, and you can find all this information on the link that's available on our website or the QR code at the check-in desk. So please complete the course survey after the conference, fill out the surveys, and your certificates will be issued to you in the next 2 weeks. And as always, if you have any problems, contact Christy. And it's now time to announce the raffle winners. And I want to have Anna and Christy available here to pick out our winner.
I'm mixing them up really good.
Okay.
Oh, well, 5.
And they have to be here, right?
5, yeah.
They have to be here.
Okay. Oh, Eric Sway.
That's really staged.
Yeah.
Eric's way. Colorado.
Yep, that's right.
Muhammad. Not you.
You were not eligible, my friend.
Bike. Perfect.
Yay.
I keep on going. One more, just one more.
I don't know.
How many do I get to do?
5. Okay.
Oh, you guys are really stumping me with your handwriting. Nizar Semsi, Senesi? No? Okay.
You lost.
Did you say? Was that right? That's fine.
Sanasi.
Okay.
3, 2, 1, moving on. Go.
Okay, Fadi Youssef?
Yeah. Okay. 2 more.
Okay. All right, Emily Wang. One more, Christy? All right, fingers crossed. All right, Cynthia Tran.
All right, congratulations to all the winners. Just a reminder, please take the time to fill out the survey and give us evaluations. We strive to make this the best interventional endoscopy course in the country. And for our trainees, that's the only way you're going to get your travel grant, for you to complete the survey for us. I want you to take your phone out and put the date for our next interventional endoscopy course, which will be held in April of 2024, April 12th to 13th, and hope you can join us in person, hopefully. With that, we bring RMI to a close. Thank you again for being a part of this. We really enjoyed it. Thank you.
Hey guys, just a reminder, there is a reception at 5:30 at the Fulganiti Pavilion. If you stop by the front desk, they'll point you in that direction. I just did.